good morning, good afternoon, good evening, wherever our participants are globally. It's my honor on behalf of Paul Collinson and Alan Jaffe, as members of the Committee of the Clinical Applications of Cardiac Biomarkers of the IFCC that represents groups from laboratory medicine, cardiology, and emergency medicine that are involved with global educational guidance pertaining to analytical and clinical applications of cardiac biomarkers. Although the recently published 2020 European Society of Cardiology, ESC guidelines for the management of acute coronary syndromes in patients presenting without persistent ST segment elevation are extremely useful, our presentations today will delineate specific concerns regarding the guidance of the use of high-sensitive cardiac troponin pertaining to laboratory medicine. Feel free during the presentation to present questions in a texting format, which we will get to at the end of the talk. On the second slide is an introduction. I name the 2020 European Society guidelines and I give the reference. And I just make everyone aware of that our committee, which is a committee comprised of international emergency medicine cardiologists and laboratorians from around the globe, did write an appraisal document that was just published online in Clinical Chemistry. You can see it online if you go into the journal. And what we did was, when we decided to do this, is because we were concerned that the document, the ESC document, had very substantial deficits having to do with the completeness of the data review and articulation, especially our educational focus is on high sensitivity cardiac troponin. We were concerned that there was a lack of comprehensiveness in literature review. The other concern we had was that few individuals with a background in biomarkers, as we are experts in laboratory medicine, that the ESC and the IFCC expert group panels, I mean, there's a separate biomarker expert panel within the ESC, was not part of the document that was drafted, and we just saw there were many gaps. Fourth, we strongly felt that that this document, ESC document, not only ignored the advocacy of the universal definition of myocardial infarction 2018, which surprisingly not surprisingly, it was endorsed by the ESC, but it also didn't really pick up on some of the early, very vital work of the high stakes group from Scotland or the troponin work done by the IFCC committee I chair with my colleagues here of the clinical applications of biomarkers. And finally, we're going to comment on the advocacy of the biomarkers and novel biomarkers endorsed by the ESC, which we do not think are yet appropriately invalidated and premature to put into clinical practice. So with that, I'd like to just introduce our first speaker, my friend and colleague, Professor Paul Collinson. He is a professor of cardiovascular biomarkers and honorary consultant cardiologist at St. George's University Hospitals of the NHS Foundation Trust and St. George's University Hospital. He's very well known to the people in the field. I won't go through his entire education. I think he's a Londoner. Of his many awards and fantastic papers, I'll just mention a couple of things. He won the first cardiac diagnostics award, which at the time was sponsored by High Test, the company, which is now the IFCC award. He actually ran the first randomized controlled trial of cardiac diagnostic biomarkers. He's published over 280 papers and review articles and abstracts and book chapters. And clearly, one thing we know Paul very well about is his superb talents and beautiful pictures regarding scuba diving and photographing sharks, especially as we have to always see the ones with big teeth. So Paul, please take it away.
Thank you very much, Fred. Can everybody see my slides? This is the most important thing.
Yes.
Right, good. Okay, well, we'll just start off here with, as you might say, something to cheer us up in these interesting times with This is in the days when we could travel. This is in fact a hawksbill turtle in the Cayman Islands, which I photographed there. So let's begin. The IFCC guidelines on clinical applications of cardiac biomarkers in acute coronary syndromes. I'm specifically going to concentrate on sections 3.33 and 3.34 when I review the question here. So let's kick off with, first of all, an overview. What are the guidelines? What do they mean? What is the evidence? And what are the implementation problems? Well, the guidelines were presented originally in 2015. They were published in 2016. They first proposed rapid diagnostic algorithms based on 2 high-sensitive assays. They were updated in 2020, and these are the 2 references. Initially, Roffi et al. 2016, and more recently, Collett in 2020. And the latest revision extends the previous proposals by including a range of assays. The pathways initially were essentially what you might call a traditional approach based on the measurement on admission and at 3 hours post-admission based on the use of the 99th percentile compared to 6 to 12 hours. So what they were initially advocating was measurement on admission at 3 hours rather than measurement on admission and 6 to 8 hours thereafter. And this is the traditional type 0-3 rule out algorithm. Patients with acute chest pain, pain more than 6 hours, you can do a single sample. Pain of less than 6 hours, it's recommending do an initial and then a retest. And we're all very familiar with this type of pathway. More interestingly, what they proposed was rapid diagnosis based on admission and at 1 hour with the use of absolute values and a 1 hour delta change. And this was predicated on the use of high sensitivity troponin assays. And this was really the big change that had occurred, that with the introduction of high sensitivity troponin assays, it was felt we could substantially reduce the sample time intervals. So this was the first rapid diagnostic algorithm, and measurement was made on admission. And if this was below a designated value, so if at the time we only had the Alexis and the Architect assays, so a troponin T of less than 5, you could have immediate rule out. If it was greater than 52, you could have immediate rule in. Everybody else was in the half and half. And then repeating the sample at 1 hour, if the initial value was less than 12 and the delta was less than 3, this would rule out. And similarly, if the initial value was greater than greater than 5 with a delta of greater than 5, beg your pardon, greater than 3, that you would automatically rule in. The key changes in the 2020 publication was the rapid algorithm followed by optional 3-hour testing. A 0-2 hour as well as 0-1 hour algorithm were offered, but the 0 to 1 hour algorithm was preferred as an option for going forward. So essentially what we have now is for suspected NSTEMI, you have a very low value, which immediately rules out, or a very low value with no delta, which rules you out, you're discharged. You have a high value, which immediately rules in, or you have a low 1 hour delta, which, a high 1 hour delta, where you rule in, and then you have an intermediary zone. So the idea is that this is specifically aimed at the population with suspected MI, and this, I think, is something you need to bear in mind, because this isn't what we see in the emergency department. We do an initial ECG, we take an initial sample, you have an initial rule out or rule in, you have a 1 hour repeat, again with a rule out or rule in, and then you have an intermediary zone that requires 3-hour sampling and further investigation. Well, I think it's extremely important for people to realize that these rapid algorithms are in fact not diagnostic algorithms, they're actually predictive algorithms, and they assign people to one of three groups. They essentially are looking at with the substantial probability of confirming a final diagnosis of AMI, according to the universal definition, is high, where the initial prediction is uncertain as to final diagnosis, where the subsequent probability of confirming a diagnosis of AMI by the universal definition on repeat testing is very low. And this really means a probability that a final diagnosis of AMI, were you to continue testing, would be less than 1%. So the rapid algorithms are based on the ability to predict a final diagnosis of AMI, and they automatically include a proportion of patients who will not be predicted correctly and require further assessment. And this is in contrast to algorithms such as the high stakes or the ESC 03 that use their diagnostic algorithms. They use troponin based on the 99th percentile. They will always include a proportion of patients that require further assessment, but this is much smaller and will be selection on the basis of clinical assessment rather than a predictive algorithm. The concern that we had was that the IFCC guidelines don't actually include a systematic review and meta-analysis of the data. They're more based on a selection of papers with, in fact, 50% plus coming from one group. In the grand scheme of things, we'd call this the expert opinion grading of evidence. Some of the proposed cutoffs in Table 5 within the document are not actually referenced, and a range of studies have in fact offered different and more efficient cutoffs than those proposed, as well as a range of different evidence-based pathways. So I thought I'd move on to the evidence. In fact, there have been two systematic reviews of the literature performed in the UK by the National Institute for Health and Care Excellence, otherwise known as NICE. The first review was in October 2014 and did in fact recommend high sensitivity troponin measured at 0 and 3 hours, and was subsequently updated to include admission measurement. But it was felt at that point there was in fact insufficient evidence for rapid diagnostic algorithms. There was then an update of this review published in August 2020, and these are the links which will take you straight to the documents. And we have in fact published the results of the meta-analysis in clinical chemistry. That's out in fact in this January's version, this January's clinical chemistry. So if you go through the process, what you find is, in fact, there are 30 studies on troponin T, 9 on the Architect, 3 on the Advia Centaur, 2 on the Satelica, 2 on the Beckman-Coulter, and 1 study on the Dimension Vista. So if we take this evidence base and look at it, what is actually the true evidence base for admission sampling? And this isn't that rule-out strategies based on admission sampling appear to be safe and robust. This is the result of the meta-analysis looking at a range of assays. But what I would like to particularly draw your attention to is that there are a range of cutoffs. The data for the Roche assay is fairly consistent at 5, but for example, for the Architect assay, 2, 4, and 5 have been looked at, 2 and 3 for the Siemens assay, 2 and 5 for the Atelica. So there isn't a single study that you can truly say dominates the market, so to speak. If we look at meta-analysis, there was a meta-analysis of using high-sensitivity troponin T for rule-out, published by John Pickering. And this is here is the meta-analysis from the troponin T studies in the NICE guidelines. There has been a randomized controlled trial of single sample rule-out. And this paper here from Young is looking at follow-up of patients in the Australasian group's studies of rapid rule-out, seeing how good these predicting algorithms really are. And there's no doubt that they do work extremely well. What about the question of serial strategies? Again, 2 things to look at. First of all, that these tend to look at symptoms more than 3 hours. They use a range of different sampling times and deltas. This is for Roche, Abbott, and Beckman-Coulter. Similar data here for Biomarkers, Ortho, Siemens. Again, some with symptoms, 3 hours, 3 hours, 3 hours. Again, a range of cutoffs. So in terms of the evidence base for short-term serial sampling, they appear to be, again, safe and robust. But sampling may be at 1 hour, 2 hours, or 3 hours, and there's actually no evidence that a 0-1 hour sampling is to be preferred. And some evidence, in fact, that 0-2 and 0-3 hour strategies are superior to 0 and 1 hour strategies. And in fact, the only randomized controlled trials which have been performed in this area, which are the high stakes and historic, show evidence for change in management. They're in fact based on a 0-3 hour pathway. But there are significant implementation problems of these strategies. And in the UK, we have been running a national project on the implementation of high sensitivity troponin. And really, we have come across 3 areas of concern. One is laboratory problems, then there are clinical problems and process problems. Just looking initially at the laboratory problems, well, it's important to remember here that the emphasis is on 1 hour diagnosis within the ESC algorithms. This means effectively we're requiring a total turnaround time. And we're not talking here about the sample arriving at the laboratory to sending the results out, but from blood sample first being taken and ordered and taken to people looking at the results, the so-called vein to brain time, 55 minutes or less if you wish to operate these algorithms efficiently. The third and perhaps interesting question is the imprecision targets which are required are less than 5% at low troponin values, and some workers have questioned whether this is in fact achievable outside of the environment of a research environment and what happens on a day-to-day basis. Clinical problems relate to time from symptom onset to sampling, a question of early presenters, late presenters, troponin kinetics. And I know that Dr. Jaffe and Dr. Apple are going to address these in their presentation. What I really want to think about, though, here are the whole question of process problems. Many of the studies are reported with time from onset to first sample of more than 3 hours. And this does then beg the question about what you do if people arrive very early. I've mentioned already that we're looking at a turnaround time of 55 minutes or less. And the suggestion has been made in the literature that 1 hour samples should be sent if the 0 time result is not going to be received. So what this is advocating is in fact de facto a 2 sample protocol, in that you take the first sample, you proceed with management, you take the second sample, and you don't wait before the first sample result. And since it's variously estimated that between 25 and 40% of the first samples will allow immediate rule out, this does create a problem in that you'll be doing a bunch of unnecessary tests. And in fact, most emergency departments have trouble implementing a 1 hour sample. And this has been our experience in the UK National Implementation Project. And if you look at the time of the second sample of 1 hour in people who've done studies, the second samples typically obtain between 1.5 and 2 hours. And this really does beg the question. So what are my conclusions on the basis of review of the evidence and practical attempts to put these rapid diagnostic algorithms into routine clinical play? Well, there is certainly very good evidence for admission sample rule out. I think the second point to say is that serial sampling overall is efficient for rule out, but there really is no compelling evidence at this moment in time that one protocol is superior to any other. And in fact, if anything, the longer protocols appear to be diagnostically more efficient. And there are significant logistical and potentially analytical problems with these very short timescale protocols. And this is, I think, the difference between research studies where samples are all run in one batch on the same analyzer and by the same medical tech analyst under idealized condition, and when you throw these things into the real world. And this has, I think, been overlooked in the ESC guidelines. But finally, and I think most importantly here, I don't think there's any doubt that the evidence that's presented looks very, very suggestive, but what we need is evidence from randomized controlled trials. We've done enough observational studies, and it's the evidence from randomized controlled trials that is needed. Well, I'll just finish now with a marine iguana in the Galapagos, and he's just about contemplating his lunch. Thank you very much for your attention.
Thank you, Paul. We're going to reserve questions to the end of all three presentations. So I do encourage the attendees to start, if they are interested, to type in your questions and get those in our boxes so we can address them. All right, so our second speaker today, dear friend of ours, Alan Jaffe. Alan is currently a consultant in the Department of Cardiovascular Medicine and also the Division of Laboratory Medicine and Pathology, Professor of Medicine and Professor of Laboratory Medicine and Pathology at the Mayo Clinic in Rochester, Minnesota. You know, Alan is one of those unique individuals as a cardiologist who truly understands cardiac biomarkers. And I think it's any major group that is going to be addressing this topic, it's important that Alan be considered to have a seat at the table because he has a very unique view through all his studies and publications and chapters he's written to understand the perspective of what happens in the cardiology community and its impact on laboratory medicine, and vice versa. When laboratory medicine brings up new tests, understanding the impact it will have on clinicians. And Alan, I'll pass over to you to help educate us and comment on the ESC guidelines that we appraised. Thank you.
Thank you. Thank you, Fred. Can everybody see my slides?
Yes.
Okay. All right, let me first acknowledge the fact that I consult for a large number of diagnostic companies. Please take that into account. My talk is going to look at when one can really use the very rapid approaches that are suggested and when one needs to be more cautious. Whoops. I'm not sure that changed appropriately. All right. Not sure my slides are moving.
Now, you might want to re-upload them to make sure they're in the presentation mode.
Yep. And okay. As Paul showed you, the rapid algorithm, hopefully you see this slide, utilizes some basic numbers. And if you have a very low value, you can rule out. It uses very close and small differences to rule in or rule out at an hour, and uses a big value and suggests that that's likely, as Paul has pointed out, predictive of subsequent MI. The data, did that come up? Did the next slide come up?
Yes.
Yes,
Okay.
Alan.
Okay, the data for this is just one of the meta-analysis Paul referred to, the one done by Pickering, which many of us participated in, that suggests that there's about a 99% negative predictive value if one has a very low value, 5, with the cardiac troponin T assay. Now, please note, this is in patients with non-ischemic ECGs. Part of this is because of the increased sensitivity for detecting injury. But part of it Did that come up? Are these coming up? Not clear that my slides are.
You haven't moved forward, Alan.
Try the space bar also.
Part of that is due to the fact that in addition to detecting small amounts of injury, if indeed you have very low values, it says you have very few cardiovascular risk factors for atherosclerotic disease, as shown here. There is a graded increase with most of the factors that cause atherosclerotic disease. So that adds and augments the predictive accuracy. In the United States, I don't know if this shows or not.
Yeah.
The FDA has only mandated that we use a value of 6, not 5, for the cardiac troponin T assay, and that degrades performance just a little bit. But there's some additional caveats. These data come from a study from Israel that looked at patients who had a very low value utilizing the Abbott assay, which has been validated also at a value of 5, and suggested that when one had a high GRACE score or was older, that the negative predictive value was diminished. This is a patient that we took care of who was 69 with known coronary disease, who came in and had negative values twice, was sent home twice, came back finally. We finally believe the clinical value. Are you seeing the angiogram? I hope.
Yes. And
you can see had a distal right coronary lesion. The bottom line is that there are exceptions, and we have a patient who had left main disease as well, that you need to take into account and be careful about. Clinical judgment here is still very important. In addition, the same thing holds for the 1 hour rule out. This is our precision profile for the troponin T assay. And although I won't immerse you in it, the reality of this is that at lower values where you have small infarctions, the ability to distinguish between 3 and 5 is going to be problematic. As a matter of fact, Pete Kavsek and I evaluated this, and Pete took, utilizing the Abbott assay, 50 random samples and set them on the bench and redid them at hour and a half intervals. And a third of patients changed criteria from rule out usually to observe or vice versa, suggesting that this precision that we're using is asking too much if we really want to make this a definitive rule out. There's a paper that just came out yesterday, so I didn't make slides of it, in circulation from Simon Mahler in the United States, suggesting that if one adds a risk score to this, one can come close. But even then, they were using a non-high sensitivity assay. So there's some cautions that are necessary. And my biggest fear is that people will accept only the troponin values and ignore the clinical implications. So what we've done at the Mayo Clinic is use the so-called 2-hour algorithm. This is the validation. We use a value of greater than 10 as a rule-in metric and a value of less than 4 at 2 hours as a rule-out metric to avoid what we know is an obligatory misclassification of a small subset of patients. The ESC algorithm also uses a high value and says it's very likely that you have myocardial infarction. And that really works all right if one is dealing with a population of patients only who have chest pain. But in the United States, we get samples often, and many of you in other parts of the world probably do as well, on a larger group of patients. This is what happens with a dialysis population. And you can see if you use 52 in patients who are on dialysis, which were not included in the trials that were used to validate this, you end up admitting 3/4 of your dialysis population on the first sample. In addition, there's a graded increase with age, likely due to comorbidities that occur in all of us. And one would then admit large numbers of older individuals if one used only the 52 number. One would also, if one raised that number, however, one might disadvantage the so-called healthy elderly and misdiagnose them, which is why the universal definition suggests that in this circumstance, both of these circumstances, it's the delta that is important. So what we did at Mayo was to jigger the 2-hour algorithm and use something like this, recognizing it's not perfect. We raised the upper bound to 100. And if one goes to the Plato trial, which was a trial of absolutely typical patients, so not only do we protect a little bit against some of these false positives, but if one looks, the positive predictive value of 100 is nearly 90%, as opposed to with 52, it's a little over 60%. So these are some times when being rapid may not be totally the right way to go, and there's some others. Here's an example that came from our emergency room of a 46-year-old gentleman who'd been having episodes for some time, and there was confusion because it started atypically like a freezing sensation in his sinuses, but it went to his chest fairly quickly. And it's been well reported. As a matter of fact, the Sweetheart study reported that 26% of the patients they diagnosed with MI didn't have a lot of a delta. And the reason for that, I'll show you, is that they were late presenters, and I'll show you that in a minute. And here it is. If you look at the upslope of the time concentration curve, it's rapid. But if you look at the downslope, it's much slower. So that if one is on the downslope, one might not see a change over 1 or even 2 hours. And in point of fact, that's what this gentleman had. His troponin was elevated. It didn't change very much, but he had no other reason for having an elevated troponin. I thought his story was pretty good, so I sent him to the cath lab and was rewarded for that. So if indeed you don't see a delta in a late presenter, maybe that's the time not to be rapid, but to slow down. Another patient that is relatively typical and confusing in some ways was a 68-year-old gentleman with lots of risk factors who had more chest pain and came in with a normal ECG and with troponins that were below the 99th percentile. No change. But the doc who was seeing him called me and said, gee, this is a rule out and the timing is perfect. We ought to see a change in troponins because troponins change very rapidly when you have real ischemia. Do I really need to do something more in this individual? And I said, if you are uncomfortable clinically, you should. And this particular physician put the patient on a treadmill, and you don't need to be an expert to see there's ST elevation in the inferior leads, duplicated the pain, and he turned out, at angiogram to have a very high grade right coronary lesion. So rule out of MI does not mean that unstable angina could not be present. And I show you this example because it's the best one where everything sort of fits together. But in point of fact, we've seen multiple cases. It ought to be that if you have the right timing, troponin ought to show you a signal. And when it doesn't, it's unlikely that acute ischemic heart disease is present. Unfortunately, we have examples like this that say that it's not perfect, so everybody needs to be careful. Here's one final lesson of a 78-year-old lady, and this is something that is much more apt to occur in women than in men, who had chest pain, and she'd had a negative workup from one of my colleagues, but she was having more chest pain. She'd come to the emergency room and had a day's worth of tightness. Because of her workup previously, people were cynical that she might have coronary disease. So they did a CTPE, which was normal, and they admitted her to my service. I was getting ready to go see her and actually worried that she was a late presenter, which is why I wanted to get an additional troponin. It actually subsequently came back as elevated. It was still going up. But what occurred before I even got to the room, my resident had ordered an echo. And they called me to say that there was a regional wall motion abnormality in the septum, confirming the diagnosis of some sort of acute MI. But her coronary arteries were normal. But if one did an MR, she had a deficit in the septum of delayed perfusion. This is becoming a more common presentation. Somewhere between 6 and 15% of individuals who have what is called MINOCA, myocardial infarction with non-obstructive coronary arteries. They are not ones who ought to be triaged based on whether they have coronary disease or not. And there is a very strong sense that if you don't have epicardial coronary disease, the guidelines, you can't have MI, and that's just not the case. And these people are not at risk. This is an analysis. It's clear that patients who have obstructive coronary disease have a worse prognosis than those that don't have obstructive coronary disease. But in point of fact, this is another circumstance where slowing down, despite the fact that coronary obstructive disease is not present, is apropos. In the long run, the principles here are clear. The protocols work reasonably well, but they're not perfect. If you want to make sure that you don't miss individual patients, you need to interpret the data in the optimal way, because the data doesn't lie. It's how you interpret it that is important. Thank you very much.
Thank you, Alan. Always enjoyable to hear you give a presentation. So I guess I will introduce myself. My name is Fred Apple. I am a professor at the University of Minnesota in the Lab Medicine Department. I've spent my career at a hospital in Minneapolis called Hennepin County Medical Center, which are now part of the Hennepin Healthcare System. Since I started training at Washington University in 1980 under my mentor, Dr. Jack Ladenson, I've been involved with cardiac biomarkers and have been fortunate in my career to serve as an associate editor over the cardiovascular area in the journal Clinical Chemistry. And as a little plug, the special cardiovascular issue, January issue 2021, just came out. Say I highly recommend it. If you can't fall asleep at night, pull it out and you read some articles. I've also been fortunate to sit on the biomarker group of the Universal Definition since 2020. I've been fortunate to be part of the Laboratory Medicine AACC Academy Laboratory Medicine Practice Guidelines in myocardial infarction and heart failure. And also been involved with teaching residents as part of our training program, the COMAC program. Overall, I would say that the ability to interact with clinicians, MDs, and as a PhD clinical scientist has really added, I think, to all of the knowledge base that we've had. And last but not least, I chair the IFCC Committee on Clinical Applications of Cardiac Biomarkers. I took the committee over from my colleague Jordi Ordonez from Barcelona, who chaired this for 6 years when it was a task force. You can read about my disclosures. So just to start off here, I'm going to re-emphasize the fourth universal definition of myocardial infarction. To re-emphasize what my both colleagues, Alan and Paul, said, we still need the 99th percentile. We still need it for a diagnostic tool. The algorithms we heard talked about are predictive tools. They're not truly diagnostic tools. And the universal definition added the ability to detect myocardial injury. It's all predicated on 99th percentiles. It's what we've chosen our line in the sand. And I'm going to continue to emphasize something the something the ESC document didn't endorse in their document, the 2020, which they did support for the universal definition, the need for 99th percentile sex-specific cutoffs, URLs, upper reference limits, when we're defining injury or myocardial infarction. Now, this is a figure taken from the universal definition, and I added 2 points to this. We've all been, all our lives have been affected by COVID since early 2020. And I put into this myocardial injury world, COVID-19. And for those of my fellow citizens and also globally, we did have some myocardial strain from what I call US electionitis 2020 as we vied to elect a new president in the United States. Now, the ESC document does talk about some confounding issues to consider. I'm going to talk about that a little later. But I'll just mention them here. This is a really nice review article in Nature Biotechnology in 2018. And we're all aware that sex, that age, that gender, ethnicity, comorbidities has some role on the increasing concentration that we do measure at baselines in patients that come in often without a cardiac history or symptomology. I know when you start to hit the age of about 60, it's a little different now, but in the old sensitive contemporary assays, you didn't have a measurable value above the limit of detection. I think everyone now, as you reach 60 and above, as you can look at this cartoon, we're seeing releases. Now, what the mechanisms are quite different, but it's going to be an interesting thing to learn. At present, the IFCC really just addresses the sex-specific cutoffs. It's much too complex, and I think it will be for many, many years to factor in age or other comorbidities when we're defining upper reference limits. A quick picture to show there's been a lot of action lately, especially in the United States, of all the regulatory CE marks in Europe. You can see the first was Roche in 2007. Now, over the last 2+ years, most of the other manufacturers either have an FDA clearance, they have a CE mark, and one company, ET Healthcare, has the equivalent of the Chinese FDA clearance, I think both their Troponin I and the Troponin T, and they designate themselves, although we haven't seen it in the US yet, as a point of care assay. Now I'm going to put up the nice figure from Paul mentioned this study. It's a really wonderful document that you should read. And I have some, I'm just going to focus in the center here, the 99th percentiles, and I'm just pointing out things in red. And these are in red because I'm going to come back to this in a table I show from the ESC document that I'm going to appraise. Just keep that in mind. Many different assays. And one thing you can see here is not all assays, even the overall or the sex specific, have a neat and clean 99th percentile that's going to be 10 to 20. And that's because no standardization for any troponin assays, even within troponin T assays, and that the way you design the antibodies, whether it's 1 or 2, capture and detection, and how you what calibration material you use to detect, you see dramatic differences. The other important document that I'm going to touch on as part of our appraisal is this paper led by Alan Wu in 2018 in Clinical Chemistry. It was the Clinical Laboratory Practice Recommendations for the Use of Cardiac Troponin in Acute Coronary Syndrome. It's an expert opinion document, combination of the ACC Academy and the task force or committee that I chaired in my group. And I highlight just a couple of things in red I'm going to focus on today is the importance of quality control, especially as we're using algorithms and making, whether it's a single rule out or delta rule outs, understanding how assays perform down around the LOD or these deltas. And that's one thing that's missing consistently in the algorithms that Paul and Alan presented when we're using numbers that are from articles. No one ever shows what the precision is around those cutoffs or deltas that are being used to, I would say, predict the probability of having an MI or ruling out. I'm going to talk about 99th percentile sex-specific reference limits. And at the end, I'll talk about interpretation, the concept of serial samples. Now, this was what Paul showed. There's in the ESC document, there are many sections that we thought had gaps, important gaps. And I'm going to touch upon a couple of these that Paul and Alan did not touch on. First, let me touch upon the idea of the importance of precision, imprecision. I just showed this cartoon from a paper my group published. The old contemporary assays are two patients that in the green rising and falling patterns according to the universal definition that adjudicated. If I gave these to Jaffe blindly, he'd say, hey, clinical symptoms, rising and falling pattern, these were MIs. When you looked at the newer high sensitivity assays, you can see there were flat lines. One was a chronic injury, the other was no injury. This is very important to understand as we adjudicate and do studies and look at data. Now, first, let me have the 3.3.2 from the ESC document, which was biomarkers and high-sensitive troponin, a quote from the paper, ESC paper. In patients with MI, levels of cardiac troponin rise rapidly. That is, they are usually within 1 hour of symptom onset of using a high-sensitivity assay. After symptom onset, we'll see a rise. In my comment, I'm just going to present a paper. This is actually a paper we just published in the January issue of Clinical Chemistry. I worked with 6 different cohorts, international cohorts. We took their data and we examined all data that was available within 6 hours of the onset of index event of that NSTEMI, all right? So there were 5 cohorts from the Abbott assay, 514 patients, and only had 1 cohort from the Roche assay, 183 patients, and a couple observations. First, the median time from symptom onset to the first blood draw were similar but a little bit different for troponin I, 3.1 to 3.5 in the 3 middle range. The time to first increase above the 99th percentile ranged between 3.7 and 3.3 hours for men and women for troponin I, and similar for that for troponin T. And in all cases that we observed, there was a statistical difference that females were less likely to cross the sex-specific URL in the first blood draw. You can see the odds ratio of 0.51 for troponin I and 0.33 for troponin T. So this thing doesn't, we might see rises, but it's still very early, especially in those early presenters, to really get a good predictive value of what might be going on. And I just show this cartoon I drew up just so everyone understands we're talking about both type 2 and type 1 MIs. I know in the US, intercity hospitals and most of the cohort studies are looking at a combination of type 2 and type 1. Most of the European studies were predicated initially on type 1 MIs, but you see different kinetics. You see much smaller increases for type 2 when they peak. And if you take 2 different high sensitivity assays, and this is comparing the same patient between an Abbott and a Siemens assay, you see different kinetics. So you have to be aware of your assay because really there will never be standardization or harmonization in troponin I or T assays. 2 cartoons from 2 different papers looking at kinetics again. The A section was published in the Journal of Applied Laboratory Medicine, and this is a series of NSTEMI patients looking at normalized cardiac troponin concentrations to the peak. You can see here, as we expect, there's a large percentage of patients in the lower left-hand corner that are not rising within 1 hour. You still see very low levels. The data from my cohort that we just published, looking at from the onset of symptoms, it's a bit of a scattergram. So depending on what your cardiac troponin I cutoff, in this case, this was all predicated for the troponin I assays for the Abbott assay. You can see here there's still a large percentage of patients, even within 6 hours, that are presenting with a normal value. Now, one of the things that scared at least the United States clinicians is, oh my God, they said that when we bring up these high sensitivity assays, we're going to see a huge increase in the number of positives of myocardial injury and a large increase in the number of MIs. In reality, that is not the case. And I'm going to document this here. It's a little misleading from the ESC document. In the troponin T world, when you go from the 4th gen to the high sensitivity, or Gen 5 as we call it in the US, because the 4th gen assay was not very analytically sensitive, here's a paper from Reichland from the Swiss group in 2012, there was a substantial increase in the number of cases found. But in the first documentation looking at a high sensitivity troponin I assay, this was the Abbott, we actually saw a slightly lower incidence of MI rates, 24%, not statistical significant. And again, this goes back to the precision. If you have a lot of noise in an assay, you can potentially pick up falsely adjudicated MIs. A second, using the Siemens assay, this is quoted, data from large multi-center studies have consistently shown that troponin I assays increase diagnostic accuracy for MI at the time of presentation as compared to conventional assays. So I'm adding another figure in here. This is implying that this diagnostic accuracy early will be better. Now, in the US, when we do studies, we typically look at all comers. In the early studies in Europe, we're looking at highly selective patients, not a lot of type 2 MIs. So if you look at this paper that was online now, predicated at Cornell in New York City Clinical Chemical CCLM, just published in the last several months online, you observe here that when you compare a high sensitivity assay for men, let's say in the lower left, compared to the contemporary assay, we see similar types of data that we saw for the Abbott assay, looking at the percentage of values above the 99th percentile. So both for men and women, we do not observe the same large increase of injury or MIs. And this, again, I think is because the power of the improvement of the analytics of the assays compared to the contemporary assay. So clinicians, if you're watching this, you will see the shift when you shift from a contemporary to a high sensitive T, but you don't see it for troponin I. And this was actually quite obvious early on. Again, a Reichland paper published in 2015 in New England Journal of Medicine. And when you looked at the 4th generation assay, which was the standard, but then you compare the Roche high sensitivity assay, which is the green bar, in this case, the Abbott blue, or the Siemens contemporary assays, the areas under the curve were no different. And that shows that really the big change occurs when you switch from a 4th gen T to any of the contemporary or high sensitivity assays. There's really not going to be that much of a difference unless you're going from the 4th gen T. This has also showed up in our own data for our Eutropia cohort. And we did see, when you look here at this is diagnostics and looking at the classic sensitivity of using an assay to rule in myocardial infarction, the dock bars are the contemporary, the light bars are the high sensitivity assay. And in our patient population, this was a 1,600 patient data set, we saw a lower clinical sensitivity for the high sensitivity assay than we did for the contemporary assay. And it wasn't until about 6 hours, at 3 hours, we started over 90%. There's where we saw the improvement for the high sensitivity assay, approaching 95%. And at 6 hours, we got a little higher, 98%. But you can see the high sensitivity assay picks up its value as we progress on into the evolution of the infarction. Now, for me, the most egregious figure in the ESC document, and I'm very outspoken about this, and I think this shows that there weren't laboratorians involved in building this figure, I would propose. And I boldly say, and I use Siemens because the Siemens 99th percentiles are much higher than a lot of other assays. We saw that on the NICE figure table, and I also show it here for four of the leading CE marked or FDA cleared. Where for males, Abbott 34, Siemens in one of their assays 79. If you were to just take a look at this just from afar, the red to me, I was taught a long time ago, means danger. So this is what they call the pathological zone. And if we're having an assay like this one Siemens assay where the male cutoff is 79, the female is 53, and the overall is 59, this would put a preponderance into concern for a user that saw the ESC document and say, gee, how can I use an assay that is already pathologic? So I think that, again, I know this literature really well, that these figures were probably put together predominantly out of the cardiac troponin T literature. As I showed you, this is what occurs. And that the zone for a likely pathological is true for the cardiac troponin T concept. From the late 90s, we learned this, but it's not an adequate representation that we have for the troponin I assays that are coming out in clinical practice. Another ESC comment was that the majority of currently used point-of-care tests, POCTs, cannot be considered sensitive or high sensitivity assays. I would tend to agree with this comment. Most of the point-of-care assays are not high sensitivity, if any are, that are used or FDA cleared. The first high sensitivity point-of-care assays have recently been shown to provide comparable performance characteristics to that of the central laboratory high sensitive troponin I and T assays. Now, I disagree with this. And the reason I disagree with this most prominently is that all of the high sensitivity proposed point-of-care systems have not been validated using whole blood. They've been used on prospectively, not been done prospectively. They've not been done on fresh specimens. They've been done on frozen plasma samples, and they've been taken out and run by 1 or 2 operators in a research lab. I will say that I am involved with our acronym is called SIEGE, Safety Emergency Department Discharge Rate. This is a study we're doing with the Siemens point-of-care assay on fresh blood, and we're very excited to see what the results do look like in a real-time, prospectively enrolled all-comers trial, at least in one site in the United States, right? So I ask industry, where are you with these high sensitivity assay, whole blood assays? We need these. Clinical practice, no diagnostic or outcome studies to data that noted have shown using whole blood. And if we do start using these point-of-care assays, the clinicians provider need to be aware that compared to the high sensitivity assays, you're going to miss 15 to 20% of true positives that you would have gotten an observation from the central lab non-point-of-care central lab high sensitivity assays. And I don't know how it is in the rest of the world, but in the United States, we are pressured to bring up point-of-care assays like ISTAT and not wait the extra 10 or 15 minutes to get the turnaround time Paul talked about of 55, 45 minutes, because the demand to get an inferior assay will have an effect on the patient care, because we're going to miss a large percent of patients on that first sampling. So the other point I'm going to comment on is other biomarkers. These in the ESC document took me a little bit by surprise, because I think real-time data, evidence-based information is truly not available yet. First in the document, they talk about myosin binding protein C, called c-MYC. They claim it's more abundant than cardiac troponin and may therefore provide value as an alternate to or in combination with cardiac troponin. So my comments, I'm going to read this somewhat, but it's a concerning recommendation. One, very few studies, mostly from 1 or maybe 2 labs. There's very few evidence-based assays. The assays used are typically higher sensitivity assays. Sometimes they're microtiter plates, and they take hours to get a result, and they're not real time. And there's poor validations outside of ACS patients, which we know as we move from the proof of principle studies, often some of these quote unquote other biomarkers fall apart. And I think anyone in the lab medicine business know it's very difficult to add a new test, especially in combination, because of the costs involved, unless there's clear evidence base that this is going to add value to patient care. The second deals with the routine use of copeptin as an additional biomarker for early rule-out of MI, and it was recommended in the ESC document as an increasingly uncommon setting where high sensitivity assays are not available. So the universal definition of myocardial infarction recommends the use of CKMB instead of an alternate marker like copeptin. We have found that CKMB using a mass assay has very good kinetics, very similar to high sensitivity assays. And I put in bold here that copeptin does not have relevant added value information for institutions using one of the well-validated high sensitivity rapid protocols for the early diagnosis. So the comments, and I put that bold comment in there because that's right out of the ESC document. So our comments and concerns in our appraisal are that concerning recommendations, authors have not shown that it adds real value to in let's say a randomized controlled trial to really look at this outside of a couple studies, not validated clearly in the type 2 MI patients or myocardial injury patients that we're seeing more of. And recent studies have shown substantial decrease in diagnostic accuracy, surprisingly, when copeptin and high sensitivity assays were used together in algorithms. So I still think there's a lot to be learned from and how these should be used. Another thing I'll throw in here is this was never alluded to and kind of glossed over. They talked about these other markers maybe being a tool for reinfarction, but I'm just going to comment this data has been around. This is one study from my laboratory, and all the in-hospital reinfarctions that we've observed, no matter where the CKMB or troponin was on that secondary index event, they parallel each other extraordinarily well and work very well as a tool for reinfarction, and this is endorsed in the universal definition. I just want to show you one figure here. This is taken from one of our Utopia studies, and Alan Jaffe referred to, let's say, the US at least. We see a lot of sick patients in our inner city hospitals. I'm not saying the other part of the world don't, but most of the cohort studies don't look at as in depth of patients who are coming in with non-ACS myocardial injury. So in our hospital, let's say at Hennepin County Medical Center, we see that one, that's in red, transitioning clinical practice, which we did back in August, from a contemporary to a high sensitivity assay did not lead to more cases of myocardial injury infarction. And we show that between the black and the checkered boxes. And this is the checkered boxes are the high sensitivity assays. So what we do observe is that the high sensitivity troponin I occurs in approximately 1/3 of all our patients that come in through our ER, and only 15% of those are due to type 1 MI. So we're seeing the large majority, double the amount of patients with injury or type 2 MI that have to be carefully looked at as we develop algorithms. I think finally, one of the last thing I'm going to talk about is confounders. Quoting from the ESC document, in patients presenting with suspected end-STEMI ACS beyond the presence or absence of MI, 4 clinical variables affect cardiac troponins. And I showed that earlier: age, renal dysfunction, time from onset of pain, and sex. My first comment is the ESC interestingly acknowledges sex as being a confounder, but does not endorse sex-specific URLs as we have in the universal definition and as our IFCC committee has. They do comment that sex-specific is an only modest effect at 40%. I find that not a modest effect that would lead to many misclassifications. Second, the comment from the ESC talks about until information technology tools that allow the incorporation of the effect of all of these variables, the use of uniform single cutoffs should remain the standard of care. This is again in direct contrast to their endorsement of the universal definition, and direct contrast to the laboratory community that studies this as a profession. And I think this is quite concerning, all right? I use the analogy, troponin is really no different in the world. We use CKMB, we use sex-specific cutoffs, we use it for creatinine, we use it for AST. We have to start learning and gain the evidence and incorporate this into clinical practice and not ignore it. All right, another confounders, this is from our IFCC website. I encourage everyone to look at the IFCC clinical applications of cardiac biomarkers website. We publish 2 or 3 times a year updates on potential confounders of biotin, hemoglobin, and what we've also observed for skeletal cross-reactivity, especially for cardiac troponin T and rare neuromuscular diseases. And keep an eye on what could confound false positives, false negatives for these assays. As far as the renal influence, I've studied this for a long time, and I'm just going to say, yes, this is an important influence. I think studies need to incorporate renal insufficiencies as part of their cohorts. On the right side of this is from the Eurotropia cohort. You can see the impaired renal insufficiency has a huge effect on prognosis as we go from dialysis all the way to normal individuals. This was a nice study done by Ian Gonzalez, who was an old fellow of mine who's now at the Medical College of Wisconsin. And then on the right side is a paper that was published from a group I work with called the High Stakes. It was first authored by an emergency medicine physician from Duke. And again, it shows you that for the diagnostics, also there's a decrease of positive predictive value as we move towards more renal insufficient patients. The nice thing about it, the negative predictive value still stays pretty solid. Finally, I'll touch on the concept of 99th percentiles. I just got about 5 more minutes. We talked about sex-specific percentiles, how we derive them. We've gotten to using more rigorous criteria where we're using surrogate biomarkers. This is not addressed in the ESC document. We're using medications, comorbidities, surrogate markers like eGFR, hemoglobin A1C, and natriuretic peptides. Clinically, we're going to see improvements and advantages for females. First, what we've observed for many of the troponin I assays, not all, we do see a very nice Gaussian distribution. We still do not see that type of information from the current Roche high sensitivity assay. There's still a bit of an askew to the right for that documentation. Now, I'm going to show 2 slides here. Well, before I skip this, just to give you an idea, look at the top part of this. This, again, shows that the troponin I and T assays are not standardized, will not be harmonized. We see a lot of different cutoffs. You can see the concept of at least a couple semen assays overall shows much different results, let's say, compared to the ortho, but they're individualized correct for each assay. Two figures I'll show the impact on sex-specific cutoffs. First is the high stakes from Scotland. For both type 1 and type 2 MIs, you can see a significant increase for women for type 1, going from an overall cutoff to a sex-specific cutoff, the high sensitivity. And we see the same thing also when we look at for the type 2 MIs in the lower part of this, published in 2015. And then most recently for the troponin T assay, this is a research letter to the editor report in clinical chemistry in the January issue. This is a collaboration of thousands of patients, of men and women, over 10 to 20, 30,000 patients. It's a look at both, I think, data from the Netherlands and Scotland. And we see an increase of rate of MI for women from 31% from the contemporary to 38%. Again, I think this is important information not to misdiagnose women based on what the ESC says use an overall cutoff. The last piece of data where these, I think, very important, which just to talk about, is the continuous risk marker, even within the normal range. So in a sense, maybe this could be a little pathologic, but we have to take a look at the concept. Even when I'm going to take a look on the right side for men, being a male presenter. This is my cardiac troponin I assay for the Abbott assay. This data is based on the Abbott high sensitivity assay. You can see as we go up, these are patients that came in through our Eutropia data set, never had a myocardial injury. But you can see here, even within the sex-specific URLs have important prognostic information. This is 100 days out, 180 days out for adverse events. I finally leave you with this slide, and I'm not going to go through it all. This is a very nice overview from the NICE study. Again, a combination of clinicians and laboratorians that looked at high sensitivity assays and observations, and it really goes through everything we heard about already from all 3 speakers. At this point, let me stop sharing here. Am I back?
You have returned.
All right. At this point, I want to thank everyone for listening to us, and we do have 20 minutes to address questions, so I will ask all the attendees to feel free to ask questions, and I'm going to read some of the questions that have been put forth and ask some of my colleagues to answer them. And the first I'm going to put to Paul Collinson. A question came, do you think that point-of-care high-sensitivity troponin assays can help to implement a 1-hour protocol? Do you believe they will be sensitive enough to do this?
I think the answer to that is that I don't think you can implement a 1-hour protocol without a point-of-care troponin, and I've gone on record of saying that. The question will be, though, whether or not the assays perform, first of all, analytically adequately, and secondly, if you put them into the real-world environment, a bit like you said you're doing, Fred, whether they will actually work then, because there's a difference between doing a point-of-care assay by someone who's analytically excellent, if you might call it, and between it being done by the enemy of all good laboratory practice, otherwise known as a doctor.
Alan, do you have any comments?
I think what Paul indicated is important, but I think I want to go back to something you said that is terribly important, which is the point of care assays thus far that are being touted have not been done often on whole blood. They've been done on stored serum or plasma. There's a big step between stored serum and plasma and getting a value in whole blood. Over and above the appropriate cautions that Paul indicates, we need to be careful because there's a lot of hype going on in this area, and sometimes the literature is less than ideally clear.
My general comment is I concur with what Paul said, so I really can't add. I think the importance of manufacturers getting their whole blood tests into our anybody's applied research labs to test them against the high sensitivity mainframe will really the evidence will speak for itself. But to follow up on another point of care assay question, I'll start with Paul also. Because one of our questions asked, there are also lateral flow assays on the market for point of care. Do you have any experience using them? And do they make sense in your eyes regarding their sensitivity and significance and bring them into practice?
I'm not aware, and I haven't had the use of any point of care lateral flow system that has shown itself to be in the real world a true high sensitivity assay using whole blood. At the moment, I'm very willing to be persuaded, but I have yet to see one.
Alan, any comments?
They will eventually arrive, and when they do, we need to be ready for them, but we need to be cautious before we implement prematurely.
And the only other thing I would add to it is, I'm not going to say definitively, but typically lateral flow assays, and Paul, you can comment on this, are typically have not been as sensitive analytically as some other forms of point of care assays. So I think we will have to rigorously test the lateral flow assays to make sure that we're looking at, we know for definition of high sensitivity, the analytical determination is being able to measure greater than 50% of men and greater than 50% of women from reference populations. So I would say if a lateral flow device meets that criteria and then meets the 99th percentile of having 10% or less CV, then more power to the assay. Would you agree, Paul and Alan?
I would agree from the purely analytical point of view, but there's one factor which I just have to re-emphasize. It's all very well doing it in a research evaluation environment, but you have to be able to demonstrate that when you put it into routine clinical use by the routine clinical users, then the assay performs as it says on the tin. And that's the crucial thing. I mean, to my mind, the one assay that we use as point of care, which is not a high sensitivity, but a contemporary sensitive assay, which was the Stratus CS. The lovely thing about that is that it has what I call exocet technology. You took your tube of blood, you poked it into the instrument, pressed a button and pushed off, and it did the rest. You've got to be able to have fire and forget technology. It's got to be robust in routine clinical use.
And I'll just add one comment, since we just got done in my research lab, we just got done doing a clinical study on a whole blood point of care device, and it was run by over 40 different laboratorians. They weren't true point of care laboratorians, because it was done in our central lab over 3 shifts. And Paul's point is well taken. How many patients had to be thrown out of the study because they forgot to put the whole blood on after it was drawn within a period of time, or they put it on the lateral flow or whatever the device was, and they forgot to look at it for 2 hours. Versus, as Paul mentioned, a mainframe instrument that once you put it on, you can walk away and still have a result that's going to be reliable. So I think we wait and see what happens. Alan, you want to make any comments?
No.
All right, next question. A colleague of mine from up in Canada. The question is, can you comment on what you consider appropriate monitoring using troponins for admitted patients? Going along the line of test utilization. It sometimes seems that a lot of testing is done, money spent from standing orders. How many tropes would be expected on an average from an admission that are really necessary after you rule in or rule out? And let me take that answer first, if I can. Then I'll pass it on to you, Alan. Right? Actually, we actually did a study. I have a fellowship agreement with a colleague of mine from Madrid, Bruno, and one of his fellows spent some time in my lab. And one of the studies she lived up in the observational unit, and she actually monitored all the troponins, about 200 patients over a period of a month that came through the observational unit, and looked at our hospital at the time used a 036 9-hour order set. And what she documented was 45 to 50% of troponins continued to be ordered unnecessarily after the provider, Dr. Jaffe, made a diagnosis, rule out or rule in. So I agree, there's a great potential to save on costs if we can figure out how to use maybe a process to cut off the orders once a diagnosis are made, to cancel it. Alan.
Once a diagnosis is made, there are only 2 potential reasons why you would want to get additional values. One is if the patient had recurrent symptoms, because reinfarction still occurs and can be of importance. That's less likely nowadays, as we're taking these people very rapidly to the cath lab. The second that some people are interested in is the fact that one can use a solitary troponin as an estimator of infarct size. Correlates fairly well with MRI. You can do that at 48 or 72 hours, a solitary sample. So once I make the diagnosis, unless something happens, if I'm interested in infarct size because I don't have either echo data or other data that gives me some reassurance, I might get a 48 or 72. Otherwise, I don't get additional troponins.
Paul?
Yeah, I think I agree. The real problem is there's over ordering of troponins. The strategy I see at St George's is if you come in with pain between your knee and your nose, you get a troponin done. And when you look at what happens subsequently, because I've just done a brief audit of that, basically only about 20% of them actually get repeat samples done, because they're only the ones that are seriously being thought about for an acute coronary syndrome. But having said that, we don't tend to see multiple ordering usually, but once people have made a diagnosis, then that's it. They don't tend to go on and on repeating it ad infinitum, I'm pleased to say. They just do too many to start with.
Okay, next question. One of the things that you two did not cover was the single order baseline sample and actually the predictive of ruling out. Is that used in clinical practice? It wasn't mentioned heavily in the ESC document, but compared to let's say a 0-2-hour algorithm, how do you use just the baseline order compared to the LOD?
Well,
Alan?
the single sample rule out we discussed quite a bit. One can use a very low number, and it varies by assay. Sometimes one can go higher than the LOD, but one needs to validate that. That's been shown, for example, by Nick Mills with the Abbott assay, that 5 turns out to maximize not only maintaining negative predictive value, but maximize the percentage of the population. It works fairly well with the caveats that I showed you, which is age, complexity, and time from the onset of symptoms to getting the sample. And I would urge you, in addition, a lot of the literature talks about time from symptom onset to presentation. It doesn't tell you that it took them an hour and a half to get the sample. And it's the time that the sample is garnered that gives the diagnostic performance, not the time that the patient presents.
I can address that. We strongly support in the UK the use of admission samples at an appropriate cutoff, and for the Roche Troponin T assay, 3 and 5 are good numbers. 5 is probably the optimal in terms of trade-off, and for the Abbott, yes, the 5 value. And we're strongly supporting this within the implementation strategy for use of high sensitivity, routine use of high sensitivity troponin, because we think the evidence for the single sample rule out is very strong. The caveats, of course, are exactly as Alan says. And what we in discussions suggest is that people use it, combine it with some sort of a risk scoring mechanism, not because we regard risk scores as perfect, but because it encourages people to do an assessment of whether or not they should send the patient home, rather than just look at a number and say and use that alone, which is bad medicine. You have to assess what else is going on with the patient before you make a final decision. But you can rule out and send home between 30 and 50% of people just on the basis of their single value. And this is a one beloved of our clinicians. It's one and done.
All right, switch. Another question is for the Troponin T users. Paul, I don't know if you use I or T, but I know Alan uses T. Question came up with the concern of hemolysis in the emergency department, which is really well documented that hemolysis shows false decreases for Troponin T. Any comments on how you use that with your algorithms if a sample is hemolyzed?
Well, we initially thought that one of the things we would like to do with that was to dilute the sample and dilute out the hemolysis. It turns out, unfortunately, that the Troponin T assay does not dilute linearly at all. And so that's not a reasonable strategy. So we have to repeat that sample unless, of course, it's elevated. If it's elevated, then you know it's elevated and you can deal with it from that perspective. But if it's not elevated, then a repeat sample is obligatory.
Okay.
Yep, exactly the same.
We'll go on to another question because we only have about 5 minutes or so. One of the individuals queried, should algorithms be amended? Does there need to be a sex-specific cutoffs, deltas for by sex? Or is there any evidence that we have to worry about a different delta for a female versus a male when we put these 0, 1, 0, 2, 0, 3 algorithms into place? Alan?
The data in regard to different deltas, although one can make an argument that there should be differences, are relatively scant. So we don't have data to really implement anything in regard to a different delta. We should, I would argue, however, implement the use of sex-specific cutoffs for all of these assays. And I think some of the studies which have honed down only on chest pain patients have not included a lot of women who present atypically, and therefore have not ended up being able to show that there are real clinical differences, which in our data set there clearly are, and that publication is something we're developing.
Yeah, I want to encourage everyone who's listening today to become a cardiac feminist and use sex-specific cutoffs for troponin values. And I think that probably the best example of this, in fact, is the high stakes algorithm, which uses a nice low cutoff for rule out and then uses sex-specific cutoffs for rule in. And I think that that's probably the best compromise. I'd really like to see them derive some data for 0-2, because I think in terms of practical implementation at the laboratory level, that's probably the best option we have at the moment.
Yeah, the only thing I'll add really quickly there on my own experience through two cohort studies is that the sex-specific cutoffs are really focused on diagnostics at the 99th percentile, and it doesn't affect it in that early rule-out concept. All right, another question. Age. You all showed and had a reference to, as we age, we have increased troponin, even though we might not have a apparent underlying myocardial injury. Will we ever get to the point where we will have a URLs, upper reference limits, that are age dependent of any reliability? Paul, why don't you start?
Oh, that's a very interesting thing and very close to my heart, of course, as I get less young. I think it gets a little, you move into a little element of philosophy here. I think if you had a perfect heart, you would always have you'd always be below the 99th percentile. We don't really know whether what we're looking at, because you certainly, as the population ages, the tendency is to have higher troponins, and this is well documented. But we can't really say whether this represents underlying occult myocardial injury, a true aging phenomenon, or something else. I think that all you can probably say is that for a given troponin level, you can give it greater probabilities, and certainly as you get older, you find that as patients are older, the ability of these algorithms starts to become a bit more difficult to implement. Go on, Alan, your turn, I think.
Yeah, in our own data sets where we have imaging and we're able to correct for abnormalities using imaging, most of the difference related to age goes away. That's not the case in every data set, but it is in our data set, suggesting that the vast majority of this are comorbidities that we accumulate over time, unfortunately. I think that as a consequence, if we try and correct for all the comorbidities that exist, since I think these that go with age are related to comorbidities, this will become a very complicated evaluation. And you'll have to balance between increased specificity of a higher value and missing the healthy individual that doesn't have comorbidities. So I think the right approach is to use it for non-comorbidities. Sex is not a comorbidity. And not to use it for comorbidities where the delta is really what one needs to use to make the diagnosis of myocardial infarction.
So I think we are done at 9, so we have 1 minute left. I'm just going to have one. I'm going to give everyone, if they want to have one concluding statement. Now I'll start first and Paul second, and we'll leave my dear friend Alan Jaffe with the last word. Scary, but I'll let him do it. Is that I hope you all will go read both the ESC document and our appraisal document of the ESC. They're both available online. Neither one are in print yet. I hope we have advocated for the importance of involving clinicians and laboratorians who understand cardiac biomarkers more clearly and have inputs into future guidelines that are important for our practices, especially in the laboratory and medicine community. IFCC is our committee that we all sit on, this educational committee. This is our role to make sure that not misinformation is put out there. And I think we will continue to advocate, whereas I ended with my little grandson, it's very important the sex-specific cutoffs become part of practice, because we're going to pick up more and more and more of this distinguishing between the subtleties between ruling in for whether it's type 1, type 2, or injury, and determining the appropriate therapies that are going to grow over time. Paul?
My concluding words are: become a cardiac feminist and look at all of the evidence, not just a small bit.
end by saying that because some of the assays came out earlier, a lot of the information is predicated on that and predicated on cardiac troponin T as a gold standard. We need to get away from that. I think there are additional facile, interesting, sensitive, and specific approaches that could be developed, but only if we take those blinders off, because if you use troponin T as the gold standard, nothing can be better than that gold standard. So there's an opportunity for us to learn a great deal, but there are also going to be exceptions to all these rules. There still is a role for us old clinicians in the emergency room.
So on that note, I would like to thank the IFCC for the opportunity. This was not a sponsored event. We appreciate the IFCC for allowing us to present this webinar, and I think all of the talks will be available on demand over sometime over the next couple of days, if not sooner. But any questions you have individually for Paul or myself or Alan or anyone on our committee, feel free to email us. We will give you what we think is the evidence-based answer, and sometimes if there's not, what our expert opinion is based on our committee. So thanks everyone for attending, and I'd like to compliment my co-speakers from London and from someplace in Minnesota called the Mayo Clinic, and myself here, I'm in Minneapolis. Thank you very much.